Good afternoon. I'm delighted to be here. I'm not sure how much mystification there is about methadone in India, but if there is any, I will try to demystify it, but hopefully provide a brief background about methadone. I have no conflicts of interest. I'm not trying to sell you methadone, I assure you. I will try to cover as much as I can in my brief time. And I will point out that I live and work in New Mexico, in the southwest U.S. between Texas and Arizona and Colorado and Mexico. And it's a very rural state. And to give you some idea of it, I looked up the square area of the square kilometer area of New Mexico, and it's almost exactly the same as Madhya Pradesh, one of your largest states. But New Mexico has 2 million population, and MP has 72 million. So that's an example of one of the big differences between where I live and where you live. And the only city of any size really is Albuquerque, of course, the birthplace and the central headquarters of the ECHO movement. And Dr. Aurora is a colleague of mine, and this is what our mountain does in the evening, just about at dusk, and this is what it does when it snows. And this is our state food, our state's favorite dish, which is green chili stew. So when people here inquire about my ability to handle spices, I always try to explain that I'm from a place where chili is used extensively. So methadone was developed in Nazi Germany in anticipation of being cut off from the opium poppy fields of Turkey and Iran when the war was being planned, because you can't really fight a war without having morphine. And so it was developed as a synthetic opioid, and that's the term. If it's synthetic, if it's made in a lab, it's an opioid. If it comes from the poppy, it's an opiate. And opioid is the generic term. So anyway, they developed this in Nazi Germany, but never really used it. And the U.S. got a hold of it as a war reparation, the output of the German laboratories, and started to play around with this interesting molecule of a long-acting opiate. And by the 50s, they were trying to use it for withdrawal symptoms. And in the mid-60s, a team of researchers at Rockefeller Institute in New York City, Vincent Dole and Marie Niswander, a psychiatrist who had worked for years in the addiction area of heroin addiction with very little success, found that this long-acting opioid would, in fact, dramatically improve people's social functioning and take away their withdrawals and cravings. And that was the incredible that was why methadone has become such the mainstay, really, of opioid addiction in throughout the world. There are over 1,200 opioid treatment programs, which is what they call methadone clinics in the U.S., and it's being used in more than 80 countries. Methadone, like buprenorphine, is on the World Health Organization list of essential medications. So this is the Dole Niswander team. And so methadone is a full agonist mainly at the mu receptor, the most important receptor for opiates. And I will point out that the full agonists, all the drugs of abuse, heroin, morphine, codeine, oxycodone are all also full agonists. And you'll see that buprenorphine is a partial agonist. And that's a significant difference, but there's certainly more similarities than differences between the two. And So heroin works immediately, and methadone takes, you don't even feel it for the first 30, 40 minutes. The duration of heroin is just a few hours, and methadone, the half-life, which varies considerably patient to patient, the average is about 24 to 36 hours. And the route is oral, as opposed to injection, snorting, and smoking. So the fact that this eliminates injection of heroin is the reason that 80 countries have adopted it. I assure you, none of them were thrilled to be starting methadone because of a lot of misunderstanding about it. But the fact is, they had to do it because of the HIV epidemics, which are sweeping our world. So, let's see, we don't have a laser, do we?
No.
No. But okay, well, I'll just point out that this is a very important slide because it shows, I can just use this, thanks. Yeah, it shows three mood states. One is being high, one is being normal, and one is being in withdrawal. So the heroin user injects here at time 0, let's see, at 0, injects the heroin, and within 10 seconds, they are loaded, they are high, and feel the heroin. And then over the next few hours, it gradually decreases, and they're in the normal zone for a few hours. But even in the normal zone, they're starting to get very nervous about the first subjective and then objective withdrawal that they will undoubtedly experience. So their entire life is spent getting high, and then as soon as they are normal enough, seeking more drugs so that they can avoid the dreaded withdrawal syndrome. So their whole life is, thank you. Yeah, great. So their life is essentially, it's not really.
I think, No, I think you use the mouse.
This one?
No, this will not be available.
This will work. Okay. Anyway, so their whole life is, people say like a yo-yo. Their entire life is consumed with getting high and getting drug. In comparison, methadone is taken at 0 hours, and within 3 to 4 hours, it reaches its peak. And the peak should be, ideally, if they're being dosed properly, in the normal range. And then they remain in the normal range because of the liver and tissue storage of methadone and its slow release. They remain in the normal range for the full 24 hours. So the next morning, when they come to get their next dose, they have not started to experience withdrawal. And so this is what methadone is. It's very simple. It's to keep people normal in the comfort zone for 24 hours a day. The best, now, the U.S., so the U.S. has had methadone for 50 years. I'm not saying that the U.S. does it the best in the world. There are many different variations of how to provide methadone throughout the world. But certainly the U.S. has the most experience. And it's very clear that methadone people need to be on methadone for a long time. I tell patients a minimum of 1 year, but when they push me more, I say, well, how long are people on insulin? How long do people stay on blood pressure pills? It's indefinite. This is a chronic disease. The methadone doesn't cure it. It simply controls it. And we've also learned that the doses have to be high, but I don't think we should even use the term high anymore. It's the therapeutic dose. The therapeutic dose is 80 to 120 milligrams. That's the experience throughout the world. It's called high because for many years, people were maintained on 30 milligrams of methadone. So 80 would have been considered high, but it's not the high dose, it's the therapeutic dose. Even a low dose of methadone will prevent withdrawal, but the higher doses prevent the cravings. And cravings are as serious a symptom as withdrawal in terms of continuing the addiction and the addictive behaviors. And finally, the other advantage of the so-called high dose is that it's a blocking dose. If you use an opiate on top of it, you cannot feel it. And the studies are, very clear that on 90 milligrams of methadone, patients could not tell the difference between being injected with saline or with morphine. They injected with the saline. They thought they were getting morphine, but it was saline. So they were blocked. And it's important. I tell patients that all the time because some patients continue to inject even on 200 milligrams of methadone. And I say, well, I just want you to know that you are wasting your time and money. You may as well inject salt water. And they look at me puzzled, but I think they get the point. So, here's one of the many studies that have been done over the years. Percentage of people using heroin, and as the dose increases to 50, 60, the number dwindles rapidly, and by the time they're on 80 milligrams, no one is using methadone in this study. Many patients fear methadone because word of mouth is it's worse than heroin to kick. That's the word, is what people say. I don't want to be on methadone. It's harder to kick than heroin. Well, there's actually some science that shows that that's only partly true. This shows the intensity of withdrawal, and heroin is much more intense withdrawal. But the methadone withdrawal is more prolonged. Heroin, maybe a week of withdrawal, and methadone, weeks. And actually, the cravings and the discomfort can persist even for months. It's obviously very subjective, but the thing to tell patients and for us to understand is that it is not as intense withdrawal, but it is very prolonged. But of course, the point of treatment is not to get off the methadone. The point is to stay on and stop using heroin. Is this a drug of abuse? This comes up all the time. Well, I can't think of any drug of abuse where people take the drug and look at their watch and say, I'm going to feel something in 30 minutes, and in 3 hours I'm going to feel really good. That's not the way people use drugs. People want to get high immediately, and every drug of abuse is injected, snorted, or smoked. So, no, methadone is not a drug of abuse. People will take it if they have nothing else. People will take it to experiment. It's an opiate, and it's always going to be of some attraction to some people. But compared with heroin, which happens to be almost everywhere in the world, people would not seek out methadone as a choice. They would seek it out if they want to control their addiction. If they're afraid of withdrawal, they can't maintain the cost of a drug addiction, and they can't get into a methadone treatment program. In that case, people will buy methadone on the street. This is considered the most studied drug in the history of Western medicine. 1,500 published studies by one count. So it's been studied. It's the most studied drug there is. We know it works. It decreases the death rate 4 to 5-fold compared with heroin addiction. It reduces drug use. It actually reduces all drug use, even non-opiate drug use. It reduces criminal activity. People get into socially productive roles. It reduces HIV, and it retains people in treatment, one of the most important measures for addiction treatment. Here's one of the HIV studies. HIV conversion was dramatically decreased for people in treatment, the yellow bar, versus people in purple who were out of treatment. I left out one of my favorite slides, which shows a 70% reduction in criminal activity within the first 3 months of being on methadone. That is why methadone is called the anti-crime pill. It's a pill that stops crime, a 70% reduction in 30 months. Now, I come from a country that has 2 million people behind bars on any day, a large percentage of them because of drug use, direct or indirect drug use. So that strategy has not worked in the United States. So we've pretty much proven that that's not the way to deal with opiate addiction or any addictions, is putting people behind bars. Put them on methadone. The safety and value has been established. This is from the National Institute of Health in 1997. So in the U.S., methadone can only be can only be dispensed by licensed clinics for treatment of addiction. For pain, any licensed medical provider can prescribe methadone for pain, but not for addiction. It has to be in a medical setting with a medical director and physicians and nurses and counselors, and there's prescribed schedules of drug testing that must occur. It's actually eight drug tests per year, and most clinics, in my experience, do it monthly. People generally start out on a 6-day-a-week schedule, meaning that they come every day except Sunday. So on Saturday, they get their Sunday dose. They get a 1 take-home dose. And that's the reason for that is very simple. People in my country don't like to work on Sunday. So we only give 1 take-home dose. Then it takes 3 months to get the next take-home dose if you are a stable patient, if you have negative urine tests for other illicit substances. So if you are a stable patient, you will then get, after 3 months, a Saturday dose. So then you come on 5 days a week. On Friday, you get 2 doses. And every 3 months, you get an additional 1 take-home dose. And within a year, a stable patient gets 2 weeks of take-home doses. And eventually, they can work their way up to 14 to 28 days, depending on the state they live in. What about take-home doses? Every country I've worked at, I've consulted in Southeast Asian countries for the last 5 years, specifically about methadone. And every country wrestles with whether to give take-home doses and when to do it and how to do it. And it really is, in Western Europe and US and Canada all have different ways of doing it. But in general, everyone seems to agree, the World Health Organization, representing consensus of best practices, says that take-home doses can be recommended when the social situation and the dose have stabilized and there's felt to be low risk of diversion for illegitimate purposes. Will there be any illegitimate purposes? Of course there will be. Of course. But the benefit of allowing people to have take-homes has been felt in every country eventually to outweigh the concern about some diversion of take-home doses. So every day at the beginning and then gradually less often, this is a US methadone clinic. The patient comes and is observed taking the methadone by a nurse or a pharmacist who in the US has a expensive computer system where the patient's name and photograph pops up and they push the button and it dispenses the methadone. But if you happen to be in Kachin State in northern Burma, where I was last year, this is what the window looks like with the methadone patients are dosing on a daily basis. And this is a bamboo building structure on the grounds of a small community hospital in a small city in northern Burma. And this is the whole methadone clinic dispensing site in Indonesia at a primary care clinic where this pharmacist has the bottle of methadone, a hand pump, and a bottle of syrup that's mixed with the methadone. And the methadone is free. The government provides it for free, but the clinics, for some reason, want to charge a few, whatever the currency is there. They say to pay for the syrup, but I have a feeling it's used for other purposes as well. But it is still quite affordable. Methadone can be misused and improperly used, and it does cause deaths, overdose deaths. And after a number of these in the U.S. Several years ago, I'd say about 8-9 years ago, there was a careful investigation, and it looked like most of the deaths were occurring for methadone that was prescribed for pain management by doctors who were switching people from OxyContin, which was way overused in the United States, a form of oxycodone. And because doctors were discouraged from using it, they were switching patients to methadone, but without really understanding that they were switching from a short-acting to a very long-acting. So most of the deaths occurred in that setting. And the American Society of Addiction Medicine and the US government convened a consensus panel to look at this issue of overdose. And what they did find that a certain proportion of the overdose deaths did occur in the methadone maintenance opioid treatment programs. And most of those occurred in the first 2 weeks of induction. So that is very important. In patients, so they either occurred when patients were being inducted or in patients who were also using opioids on top of their methadone, and patients who were using other CNS depressants, and that was specifically benzodiazepines, which are a problem wherever methadone is used in countries where buprenorphine is available. So as a result, this panel put together a guideline that I will leave a copy of here and an electronic copy, and anyone is welcome to review it. I think it's very well and very good review of the world literature, and comes up with very practical guidelines for methadone induction. So methadone induction, it's not rocket science, as we say in the U.S. I don't know if you have that expression. It's not that complicated. It's but it has to be done correctly.